So I'm Rory, as Manu said, and the goal of this is kind of just to introduce the concept of push dose pressors, but mostly push dose epinephrine because that's the drug we chose to use in our centers. What it is, why we use it, how you use it, so on and so forth. And so the first thing is what is the concept of push dose pressors? And traditionally, pressors are thought of in two forms. Essentially, the doses one would use as an infusion, and the doses you get in a stick that typically you give during a cardiac arrest when the patient has no pulse. And those two doses vary by 10 to 100 fold depending on the doses you're using. And push dose pressors is essentially a bridge of those two gaps. A push dose pressor is a vasopressor agent in doses that one would use for an infusion, but pulled up in a syringe, and so you can microdose your pressors as you're waiting for an infusion to get to the bedside. So a common example, if you take a standard norepinephrine infusion at 4 milligrams and 250 cc's, that comes out to 16 micrograms per cc. And so if you pulled up 10 cc's of that and used it as a push dose pressor, each cc you give would be 16 micrograms. And you'd essentially be giving the same dose one would if you were running it through a vasopressor line as an infusion. Now that's fairly complicated. So the goal of this was to make a much simpler version of push dose pressors. I can keep going if you want. Yep. So that's the idea of push dose pressors. Now, push dose pressors come in many forms. Epinephrine, norepinephrine, phenylephrine are usually the most common that you see people use, and they each have their own flavors. But in the end, most of the differences between them are academic. And so the goal of creating a push dose pressor protocol was to create a uniform pressor that one was giving to avoid a lot of the common errors which come in the way you mix it and dose it, and the differences between doses of phenylephrine, norepinephrine, and epinephrine. Sumeet, I don't know if you want to chime in on any thoughts because you started building this protocol.
Yeah, that's a pretty good summary of what we use. I can't say that I've ever in practice used norepinephrine as a push dose, honestly. I don't know if I'd feel comfortable with not as much literature, but yeah, that sums it up pretty well. We're lucky now that we have kind of manufactured push dose pressors, so that kind of takes a lot of the stress out of the concerns for, I guess, medical errors and safety. And yeah, it was a lot of fun to kind of put something like this together. And like I was telling before we started, it was probably one of my more meaningful policies to work on.
So I guess the next step is why would one use push dose pressors? What's the point, right? We have vasoactive infusions. Why not just start a drip on someone? And the way I look at it is a push dose pressor is a bridge. It's a bridge of temporary, simply a temporary infusion until you can get an IV pressor infusion running, or the patient doesn't need it anymore, as they're having transient hypotension. And this can be used in various circumstances. The most common time we see this in the emergency department is during intubation, as patients often will have peri-intubation or hypotension and arrest. Manish, I understand you did a little digging on this data. Do you want to speak to that?
Yeah, and so I'll ask everybody in the group to kind of think through in your own mind, based on your own experience. Know that across our 9 emergency departments, we do about 2,000 intubations per year. So what percentage do you think become hypotensive post-intubation? Think through your own experience and how often you've experienced it. And the answer to that, at looking through our data, are 28%. So 1 in 4 of our patients post-intubation become hypotensive. And what's even more interesting is in patients who are normotensive, 15% become hypotensive post-intubation. That's the MEP experience. Rory, you might be familiar with national data.
Yeah, so the global data on this is fairly similar. It's 20 to 25% of patients who you're intubating in the ED will become hypotensive. About 2 to 3% of them will go on to have a peri-intubation arrest. The most interesting part is we don't really have any great risk factors identifying which ones you can say this patient's likely to get hypotensive, this patient isn't. The obvious one, patients are hypotensive prior to intubation are likely to still be hypotensive after you push your RSI meds and add positive pressure. But outside of that, there isn't really any good risk factors. For a while, people were trying to use the stress index, which is a ratio of the heart rate to the blood pressure. And having a stress index was somewhat indicated of people having peri-intubation hypotension. But if you look at the data on it, it really is only about 60% sensitive, meaning it's fairly specific. If you have a low blood pressure and a high heart rate, yes, you're likely to become hypotensive during the intubation period. But if you have a normal blood pressure and heart rate, it can't tell you that you're safe. So essentially what this means is you kind of have to prepare for hypotension to some degree in all patients that you're intubating in the emergency department. And that can vary depending on the site you are, how fast you can make vasopressor infusions, so how quick your nurses are at getting those up. But essentially, from my view, is your options are to have a vasopressor infusion ready in the room on every patient, which is somewhat a waste of resources, or have some push dose pressors at the bedside, which again is a much smaller resource and will allow you to bridge you to the point where you can start a vasopressor infusion.
Rory, if I can add to that, like I would say there's a group of patients that we all intubate that are, profoundly hypertensive, the head bleed, whatever it might be, where it's highly unlikely that that person is going to need it. In almost everyone else, I would consider taking it into the room with you. Now, we're fortunate at a hospital center. We have it in both of our Pyxuses, and we can get it pretty quickly. But I would say have a pretty low threshold to take it in your room, because I think that's probably the single riskiest procedure we do, where you're going to have the highest proportion of your patients become hypotensive post-procedure or intra-procedure.
Yeah, I would argue you take it in the room for anyone just based on this data. And, even the head bleeds who don't get hypotensive also, they take hypotension very poorly. They just don't tolerate it well. And so even then, you really, if a septic patient who gets a little hypotensive and you can bridge them through it, it's not a big deal. But, the more episodes that a head bleed has of hypotension, the worse their outcomes are. So, I mean, in those patients, you want to be very protective of managing that blood pressure.
That's a great point.
So I guess the next step is what are the medications we're talking about? Because like I said, the choices I kind of ran through, norepinephrine, phenylephrine, epinephrine are the most common seen. What we chose to do at MEP was to use epinephrine. And the reasons we chose that, Sumeet, why don't you tell me the reasons you chose it? Because I have my own reasons, but I don't want to presume.
I don't think I really chose it. I think the drug chose me, and I just sort of got looped in on it, quite honestly. Mm-hmm. I think it's probably the most common and most asked for in situations. I'll give you a little background to my experience that it's come up before this policy. It's usually a resident that will ask for it, and the rest of the team, nurses, everyone else, doesn't know what they're talking about, and that's kind of where a lot of the errors would take place. So yeah, I wouldn't say that it was something that I chose, but I do see the need. It's way more common to use for sure.
Yeah, and I, from my perspective, I think epinephrine has a bunch of theoretical benefits. You get both alpha and beta, and so in the undiagnosed shock patient where you're not sure what their cardiac function is, you're not too worried about afterloading them and straining an already stressed heart, and so you can add some beta there. The theoretical downside is you're adding more chronotropy to a patient. So, in certain patients with AFib with RVR or something like that, you might exacerbate some of their chronotropic effects. I find that's mostly academic, and in the real world, it doesn't matter very much. And the ones that you're really worried are the ones that aren't crashing, and you can, start an infusion of phenylephrine if you really don't want the beta effects of the epinephrine. And so, when we were trying to create something, creating a protocol that has one drug to avoid confusion with single dosing, epinephrine gives you the most versatility. And that's kind of why we went with it. Now, what you described was, the wild west of push dose pressors that was not so long ago, which essentially we were mixing our own push dose pressors. And I trained in a residency program where it was fairly slow to get both infusions and push dose pressors to the bedside. And so we became very comfortable both mixing our vasoactive infusions at the bedside as well as our push dose pressors. And so it's been in my practice since I was a resident, but it can get fairly confusing. Essentially, the dose you're trying to achieve is 10 micrograms per cc. Similar to an infusion you'd be giving someone at the bedside. We start our pressor doses somewhere between 5, 10 to 20 micrograms per minute, right? And so if you bolus 10 to 20 micrograms per minute, you're kind of achieving a moderate dose pressor regime with your push dose. And so in the olden days, what you would have to do was take a code card epi, which was 100 micrograms per cc or a milligram per 10 cc's, and you take 1 cc out of that and then pull up 9 cc's of normal saline, and that would give you 10 micrograms per cc. That was a reasonably simple thing to do once you became familiar with it. But then we had epinephrine shortages, and you were getting epinephrine in 1 milligram doses, so you would have to double dilute it, which means you take out 1 cc, add 9 cc's of normal saline, squirt out 9 cc's, and do it again, and that would give you the right dose. So obviously, all of this can get fairly confusing and lead to a lot of dosing errors. So what we've done now is standardize this by getting push dose epi sticks in our Pyxis,
which was a great success. I'm really happy we were able to get that. And I think it was largely the push of this group, this physician group, honestly.
Well, Sumeet, there was much more than just that, right? I just want to take a moment and thank, it was a great collaboration between pharmacy, MEP, and quality and safety. And it was all three coming together to push it out. And my hope is, and I believe it's in all 9 of our emergency departments now, pre-mixed to go. Rory, I wonder if you would talk briefly about a dirty epi drip. And I ask that because that's in DCEMS's algorithm. I don't know if it is for our Maryland colleagues.
So a dirty epi drip is essentially you take 1 milligram of epinephrine, so a code cart stick, and push it in a liter of saline or LR, whatever you have, right? And then you're running it at essentially 1 microgram per cc. And so it's a quick and easy way to do simple math that you can create an epinephrine infusion. The worst part about dirty epi drips is they're not run through a pump, right? And so it's the run to goodness effect where you're essentially titrating your epinephrine infusion to whatever the blood pressure is and whatever the blood pressure you want. The argument for it is if I have no other way to run epinephrine or norepinephrine or a pressor, then that's what I'll do. And because I have it at such a low concentration, I can have a little bit of room for error. Anyone who knows anything about this does not feel good about that. I think dirty epi drips anywhere where you have a pump in a modern emergency department is probably not the way to go, right? That's what a push dose pressor gets you, is a bridge to an actual standard infusion where you can get a pump and you can know how much you're dosing to avoid a lot of the catastrophic dosing error that you can get with, you're just running a blind infusion into a patient. Not to mention, it looks like a bag of saline. So if you don't label it right, you're not sure which one's your epinephrine drip, which one's your saline resuscitation, and it can cause all kinds of problems. But if you don't have pumps and the ability to run pressors otherwise, and you don't have someone at the bedside who can push dose epi over and over again, there's an option there.
And part of the clinical practice guideline that Sumeet had and then initially written includes how to mix it. And look, there's the possibility that we go on shortage again and we have to mix it again, but certainly having it pre-mixed in the department allows us to take away the 2 most common or the 2 most feared errors, I would say, the dilution errors and the not labeling the epinephrine, which again, I think was huge. Also just wanted to mention that this was the outcome of a failure modes effects analysis that our quality and safety team took us through. So this was I looked back at my emails, and the initial emails that I got from Eric and Sumeet were a year ago. It took us that long to kind of allow it to go live. But I think hopefully in the right and sustainable way. Kate, do you want to mention anything about that?
Yeah, no, I was just going to say this was a great collaboration, and in that process, the multidisciplinary team really walked through all the potential sort of things that can go wrong. So Rory, you just did a mini FMEA on dirty epi drips, and really came to the conclusion around this process. And so I'm grateful to this team for walking through that. Can be kind of tedious at times, but I'll say we've had a couple of serious safety events around the system around epi. And so this is a great benefit to have on hand when we're doing patient care, but getting it out there as safely as possible was a real team effort. So I'm glad that we managed to do that.
And Rory and Sumeet, there's a great question in the chat. Candace is asking, in a scenario where you don't yet have a drip available, how soon can we redose? And as a corollary and as a follow-up to that question is, what about infusion of, because we're talking about short-term, right? We're just using the push dose. What about infusion and the requirement for a central line? Because I know there's various policies that are in place. So if you can, in answering Candace's question, also talk about what the few hour game looks like, the 3 to 4 hour game looks like after you utilize the push dose.
So there is no technical limit on dosing and frequency, right? You're basically, you think of it as an infusion of epi or norepi, right? There is no one dose for everybody, and you titrate your infusion to your MAP. And that's what you do with your push dose epi. Much like anything, you start small and you titrate up. And so I usually, depending on the acuity of the patient and how low their blood pressure is and how quickly I'd like it to come up, push 10 to 20, so 1 to 2 cc's. And you see a reaction very quickly, right? Within 30 seconds, you'll start to see a change in blood pressure. And that dose lasts, 2 to 3 to 5 minutes, and I'll dose again depending on what the blood pressure is at that point. And so you can dose as frequently as they need it. Now, most people can get a drip up and ready in 5 to 10 minutes. So usually, at most, you need to go 1, 2 to 3 doses of epinephrine before your drip is ready. And so, if you think about one stick, you very rarely need to go to a second stick. It's happened, but very rarely do you. It also helps you figure out what your dose of norepinephrine is going to be when you get them on pump, right? If you're giving 10 mics every few minutes, you can start probably around 10, but if you're pushing much more than that, your initial dose probably has to be higher. As far as moving to pressors and running pressors through peripheral lines, that's actually something else we're working on, which is a peripheral pressor protocol, which obviously we'll have to run through the standard procedures. But what it looks like it's going to come out to is pressors can be run through a peripheral line for up to 24 hours, up to about 25 mics a minute. Again, this is not approved. This is something that hopefully, over the next 6 months will come through. But in the emergency department, you can run pressors for a reasonable time until you have a central line established. And it's the clinician's decision, and judgment to be like, hey, I think this is someone that we get source control. We do a little fluid resuscitation. They're not going to need pressors in an hour. I'm not going to put a central line in. But, when you're titrating up your pressors fairly rapidly and you're thinking about starting a second agent, that patient probably needs a central line. You're not going to get away without it. But the answer there is not to continual push dose epi to avoid a central line. It's just start the vasoactive peripherally and then make a decision downstream whether they need a central line or not. Did that answer your question?
I think so. Candace, if that didn't answer the question, please just restate it, please. Dave, I wonder if we can loop you in and hear your perspective on push dose epi. Obviously, you've got many years of experience using it both at MedStar and at your previous facility. And that's Dave Shifrin.
Oh, I'm sorry, were you? Sorry, sort of cut off there. So yeah, we've had a lot of experience with it. We actually implemented this policy at my previous health system about 4 years ago. and started getting the medication compounded. And we utilize it for the same thing that Rory has already discussed. I mean, the vast majority of these patients we used it for was for that peri-intubation hypotension in order to get their systolic blood pressure up. Because as we know, a portion of these patients are going to drop their pressure. So, if they come in with their systolics less than 90, that's something we want to avoid. We carry the same concentrations. We would do 10 to 20 mics a minute to sort of piggyback off Candace's question and what Rory has already said. The half-life of it is less than 5 minutes. So you just continue to dose till you see effect. While there technically is a max dose of epi, there really isn't a max dose of epi. If you look at some of the literature that's out there, in some patients, you can go upwards of 2 mics per kilo per minute in septic shock patients. So you're looking at pretty high doses. And then in terms of peripheral administration, once again, just to echo what Rory has already said, we need to utilize and do what's best for our patients in the emergency department. So even if we have peripheral access, it shouldn't preclude us from starting an infusion. Even if we have to temporarily go above what our max will be, that 25 mics per minute, we just need to do what we need to do in order to maintain adequate MAPs for these patients post-intubation or whatever the case may be. The only thing that I have reservations against is just make sure that peripheral line is obviously a good line. If it can be ultrasounded, better, and just make sure it's not near the hand. I mean, those are my only major reservations. But yeah, in terms of the medication, it's very well tolerated. In terms of some of the reservations I've gotten from some of the physicians I've worked with in the past is, hey, our patient's got a heart rate of 170, 180. Should we really be doing the push dose epi? And even though it does have that beta activity, we need to look at obviously the physiology of what's causing them to be tachycardic. And a lot of times they're in some sort of shock state or hypotensive, and us correcting that shock state or correcting that hypotension will oftentimes bring their heart rate down. So I never hesitate to utilize our push dose epi in these patients. And I've never pushed a patient to, severe tachycardia over 200 or anything like that.
Yeah, I think Dave brings up a good point that it's important to remember that push dose epi is a bridge. It's a bridge to something, right? It's a bridge to a pressor and infusion. It's a bridge to the patient kind of getting through the peri-intubation pressor period and no longer needing a pressor. But certainly it's a bridge, and you should understand what the physiology is that's causing it. And, in my idea, and this is probably kind of getting off the concept of push dose pressors and going to pressors in general, pressors don't fix anything. They get you through something until you understand what's causing the shock and you can get source control, right? And so while there is no limit to the dose of pressors we can give, much like Dave said, you can go up to massive doses of norepi and epi in septic patients. You have to ask yourself what's happening, because that shouldn't be happening, especially in the emergency department. To see vasopressor refractory shock is a rare thing, and it means you don't have source control of something and you have to go find it. And so again, you utilize your push dose as a bridge, but you have to kind of move farther to figure out what's going on with the patient.
I can just add 2 kind of tangible cases I had in the last month. I think we talked about the importance of using it post-intubation hypotension. I had 2 cases in the last month where I used it pre-intubation, and one of them was in a guy with a massive upper GI bleed who ended up having a variceal hemorrhage whose pressure dropped in the 50s. Now, in general, with GI bleeds, I try not to get the blood pressure too high, but he needed to be intubated, and I wanted his pressure reasonable before we paralyzed him. So used push dose epi just to get his MAP up to 60. It was great, worked out beautifully. The other one was a person who came in with a MET to the spinal cord who had a non-traumatic, sudden, high C-spine fracture with a neurogenic shock. Same idea. Pressure was very low, used the push dose epi to bridge us to a drip that we had established, and then safely intubated the patient. So can definitely be used, and I would say should be used in that pre-intubation phase as you're prepping somebody to be paralyzed.
Yeah, I think that kind of bridges us to how do you use it, and that's a great point. So pre having the sticks, essentially what I would do is anytime I ask for pressor, I'd also ask for an amp of code card epi, mix up my push dose epi and bridge them to the drip as the nurses were making it. Nowadays, I can, anytime I ask for a drip, I also ask for an amp of push dose epi, and then again I can bridge them until they get on their drip. And you can be as aggressive or non-aggressive depending on the patient and how much you think they need to have their MAP defended, and if they can wait for their IV infusion. One of the comments that I think we have to say is, and Manish, I think your case was unique, that you wanted to maintain a low but normal blood pressure, and so the push dose was great. Most patients who are hypotensive pre-intubation will be more hypotensive after the intubation and probably should just be on a vasopressor drip, right? And so those patients, the push dose is probably not the move. Is just start the drip before you intubate them. You can have push dose ready in case you need something extra, but having the drip on those patients is probably the win. But any patient that you're actively going to get a drip, having the push dose to the bedside to help that bridge can be helpful.
So team, we are just over 30 minutes in, and I wanted to see if there was any questions that weren't answered, any experiences that our colleagues have with push dose epi that they wanted to share. While people are debating, unmuting, Rory, Dave, Sumeet, any other comments that you'd want to leave the group with?
I would say just, especially now that it's so easily accessible and no longer do we have to do like bedside math, just kind of have the sticks with you. The more you're comfortable with them, the more you'll see how handy it comes. And I can't tell you how many times it's kind of saved my butt in patients that I thought were going to be just fine and they got into trouble. And just having that ability to be comfortable with those kind of bridges really kind of adds to your care.
Hey Manish, one quick question for the panel is, in the setting of push dose epinephrine, especially a patient who we are thinking that they may or may not need an infusion following the bridge. A lot of times we would reach for norepinephrine, right? And we're doing push dose of epi, but we would probably, if we weren't using the push dose, would just use norepinephrine. So just if you could comment on that, like, if we use the push dose epi, that doesn't sort of box us into using epi, right? It's still perfectly fine and sometimes preferred just to go to Levophed.
Yeah, so you're using your epi in its alpha doses. So epinephrine, it has both alpha and beta, right? So it's both an inotrope and a vasopressor. If you're going to use epinephrine as an inotrope, you tend to use it at fairly low doses, so between 1 and 10 micrograms. It's mostly a beta agent. It has very little alpha. When you're using it as push dose form, you're above 10 into 20 range, and so you're using it as an alpha agent. You're essentially using it as norepinephrine. So switching over to norepinephrine, really, you can pretty much go to the same dose that you're using at epi. It does make you wonder, technically when people say they're adding a second or third line pressor and they're using epinephrine, they're not really adding another pressor. They're just adding more norepinephrine in a different name, right? And so, yeah, they're essentially, you can trade them back and forth. There's slight differences. Academically, norepinephrine has less beta effect and might have less chronotropy. But just to make things simple and make it easier, in the chaos of resuscitation, sticking to one agent is probably the best way to go.
Good.
Yeah, just speaking on to what Rory was saying, as we know, norepi tends to be first line for pretty much all forms of shock, except for a few very rare instances. So even though we're using that push dose epi, I still would recommend a norepi drip.
Yeah, I think not to push ourselves, but we're going to have another pop-up quite shortly on just looking at pressors and inotropes in general and the concepts between them and how you think about norepinephrine and epinephrine. And so I think we can get into more details there. But essentially, just quickly, I tend to use epinephrine as an inotrope in its low doses, using it as an infusion and norepinephrine as a pressor, and split those up. When I'm using a push dose stick of epi, I'm using it as a pressor.
Okay, fantastic. So we're at 2:06. I think we should wrap up there. Again, I'll close with, I think this has been a tremendous success. It's been pulled more than 100 times in the last 4 months. If you haven't used push dose epi, I hope you feel a little bit more comfortable with it. I'll add one last statistic, and this is again based on our own data. 6% of our patients post-intubation arrest, and these are not patients who are coding pre-intubation, 6%. And I do wonder if we had push dose epi, if that number would be less, if we were using it more frequently. So I'll leave you to think about that. Our next pop-up is March 30th at noon, where we're going to discuss vasoactive agents. Rory and Max Hochstein will join us to talk about vasoactive agents. Again, all of this information, clinical practice guidelines, guidance documents available at mepcc.net. And then also please take a look at the YouTube page. It's just type in MedStar Emergency Physicians at YouTube and you'll find us. Thanks, everyone.
Thank you, guys.
Thank you.